A lot of times when we are managing an airway, it involves maintaining patency, and if there is something blocking the airway, we may be able to suction it out. If it's secretions or fluid, we do have to understand that when we're suctioning that it can cause some issues such as hypoxemia. So often we want to hyperoxygenate a client prior to suctioning, and we want to make sure that their oxygen level returns to its pre-suctioning levels, at least return to pre-suctioning levels following suctioning. There are some cultural issues regarding suctioning, such as some Vietnamese or Southeast Asians may believe that objects that go into the body might cause illness, so some may interpret suctioning as introducing an illness to a client. Make sure that you provide any education that's necessary prior to suctioning, because it can be very frightening and it can also cause some gagging. Make sure you know what the client's vital signs are prior to suctioning. Certain disorders such as COPD, asthma, cystic fibrosis, pneumonia, trauma, abdominal or thoracic surgeries can place clients at an increased risk for obstructed airways. If a client has a history of any nasal trauma, then polyps, deviated septums, chronic sinusitis, allergy problems that have that swelling of the mucosa, all of those can affect your ability to easily pass a suction catheter. Smoking can also alter the body's ability to clear secretions. Enteral feedings, nasal or oral tubes, decreased level of consciousness, a decreased swallowing ability, all of this can place a client at an increased risk for aspiration. So make sure you know your client's history and identify any situation that may increase their risk for aspiration. During suctioning, if the client is able to cough, this is good because it helps to bring the secretions up to a level where the catheter might be able to get them out. Make sure your client is sitting in a high or semi-Fowler's position. It's never a bad idea to drape them to help prevent soiling of the linens or the gown. Wash your hands, use clean gloves. Use a mask if you think splashing might be likely. You'll need a cup that has some water in it so you can help clear your suction. These are some different devices that you may be using. The upper left is called a yonker. A DeLee suction is what we use in newborns to help suction the newborn babies, as is a bulb suction. And soft suction catheters are frequently used for nasopharyngeal suctioning. Sometimes it can be used for oral suctioning if you need to go a little bit deeper than what the yonker can reach. And there are some pre-packaged suction kits, such as what is shown in the lower left. This is frequently used for patients that may be on a ventilator and they require. So when you're suctioning, understand that oral suctioning can be delegated to the CNA, but the nurse must complete the assessment. You'll insert the catheter into the side of the mouth and move it around until the secretions are cleared. Replace any oxygen that you might have had to have removed. Make sure that you cleanse the catheter with water or saline until that tubing has been cleared of any secretions. Repeat as necessary. Make sure that you understand that suctioning removes oxygen, and it can cause your patient to become hypoxemic. So monitor oxygen levels very carefully when you're doing suctioning. You should never suction for longer than 10 seconds at any time. Suction should be off when you insert the catheter, if at all possible, and then you suction as you withdraw the catheter. Sometimes rotating the catheter from side to side, gently moving it around from one side of the mouth to the other. When we do oropharyngeal suctioning, we're going a little bit deeper. Again, you're going to insert the catheter into the mouth, usually along the gum line until you reach the pharynx, and you move it around until the secretions are cleared. Do not apply suction if you have that option as you insert the catheter, because it can grab tissue and actually cause some trauma. Make sure you rinse the catheter out following suctioning. Repeat as necessary, but again, you don't want to suction more than 10 seconds at a time, and you may need to allow the patient 1 to 2 minutes to readjust or get back to their pre-oxygen or pre-suction oxygen. Nasopharyngeal suctioning cannot be delegated to a CNA. It does require aseptic technique, and you will use sterile water and sterile saline. It requires lubricant, requires sterile gloves. Suction catheter is connected to the suction tubing with the non-dominant hand. The non-dominant hand will no longer be sterile once you connect this. Again, no suction during insertion. You quickly insert the catheter into the nares. Make sure you follow normal passageways and don't force it. If it's not going to go, then stop. Once you get to the back of the nose, you have to make that turn, and it can almost feel like resistance, but if you give it a little bit of a twist, it usually will slip on down. In adults, the catheter will go about 6 inches. Children, 3 to 5. Infants, 2 to 3. If you'd like to measure, you can go the tip of the nose to the angle of the jaw, and that will the tip of the nose to the earlobe is going to give you a pretty accurate measurement as far as how far it should go down in that particular patient. Again, suctioning 10 seconds up to 15, but 10 is really the rule. Slowly rotate as you slowly withdraw. And rotate means turning it back and forth. It doesn't necessarily mean turning it all. Make sure you rinse the catheter out again. Don't use the same catheter for more than 2 passes with nasopharyngeal suctioning. You need to allow at least 1 minute between passages to make sure that the client's oxygen levels stay up. It does increase intracranial pressure, so make sure that you hyperventilate these clients if they have a head injury. If a client develops respiratory distress during suctioning, you will immediately